know
It was a struggle
for
today for everybody.
next week
Hardly anybody's
specifically.
here.
We're not going to cover latex allergies. We're going to cover those probably in another somewhere else maybe. Always know the differences between your precautions. What kind of things get put in airborne precautions? What kind of conditions?
Tuberculosis.
TB, what else? COVID still is. I know. Depends on the day and the flavor, maybe. Chicken pox. Chicken pox goes in airborne precautions. Yes, really. Because if you and I are sharing the same airspace, you cannot touch me, you cannot get within 6 to 8 feet of me, and I can still get chicken pox from you. So chicken pox is airborne precautions. That's a fun fact, now you know. My daughter, when she was little, she went to the movie theater, and she broke out with chicken pox the next day. She probably infected everybody in the whole entire movie theater. I'm just saying. Droplet is what kind of circumstance? If they can cough on you, right? Droplet. Contact's pretty self-explanatory. And sometimes when you get to these kinds of questions during your NCLEX or an ATI question, sometimes as nurses we just want to put it all on, right? We're like, just put it all on because we're just going to protect everybody from everything. That's not what NCLEX or we or ATI want to know. You know how it gets transmitted, therefore do you know what to wear to protect yourself and be cost effective and be smart about it. So then I want you saying I'm going to put everything on for every condition, the long and the short of it. And as a caregiver, if you're aware of what goes into what kind of precautions, it's easy to implement those. Err on the side of putting them in precautions until you get those results back. You can always take them back out of precautions versus wishing you had them and you're backtracking. All these people have been exposed to that patient. If you hear that word cohorting, that means putting patients together that have similar circumstances. So as we talked about the patient with neutropenia, you would never room that patient with another patient, period. So that word cohorting means if you have to make a decision and you're the nurse manager today and you're trying to figure out patients you have to put in combined rooms, we got those because of construction today. And I got to combine rooms. Think through, do they have anything that might be infectious that you'd want to not put them in a room with someone else? So I give you the patients that are undergoing chemotherapy treatments or undergoing cancer treatments, and I give you a white count of 2, an A and C count of 500. Don't cohort that patient with somebody else at all. So could you make decisions on that given that information? As you know, there's lots of nurses and things out there. Don't need to cover anything more with that. I don't know why this was part of the chapter that it was. I'm not going to spend any more time on it. We already covered infection control before. Anybody have oncology questions? Do you feel like you're pretty clear on what kind of things are most important to know about your patient that has cancer? Any questions on what we covered so far today? Any questions? We'll go over those.
Yeah. It feels like it's low blood pressure.
What?
Scary.
We'll go over hematology here in a bit. Hematology we're covering entirely separate from what we just went over, so we'll tackle that here in a bit. So the test next week will be half renal, last week, a 4th oncology from this morning, and a 4th hematology, which is coming up. That's how the test questions get divided next week. How many questions next week? 50. So there'll be 5 or so dosage calculation questions, which means there's about 45 content questions, which means there's about 22 from last week, about 11 from this morning, and about 11 from hematology this afternoon, is how it kind of gets divided out. And your final gets divided by 11 weeks equally, because you had 11 weeks of class, at 5 weeks of test. So your final gets divided by, you'll have 8 or so dosage count questions on your final, which means you have about 7 or 8 questions per week. Which means you'll have 24 mental health questions, because that was 3 weeks of time, right? I know I saw the drones come back and row, but that's the way it goes. Okay, we're going to switch to hematology. I'm going to figure out where my NCLEX questions went. We can kind of cover those together. Maybe. Did anybody not take a handout last week? If you did not take one last week, here they are. I didn't run more off after last week. I assume that if you took one last week, you're going to bring it today. If you weren't here last week, I've got 2 handouts for the next hematology session. I hope they were helpful. I don't know. It feels like it's a lot when I get to hematology. Plus it's the end of the day and the semester.
I'm gonna ask her like after test D next week if we can have like a review after class for the final. Just gonna see what she says.
Yeah, that would be cool.
Huh. I'm gonna ask her if like next week after test D, if she'll hang back and we talk about the final a little bit. Cause for test C, the week before after class, she did like a little review with us, and I think she's gonna do it again today.
Hey, Daniel.
Yeah, it was. And she's gonna do it again today, I think. Stay after class and do a little review. I think so. Sure. Okay, sure. So, yeah. Yeah, sure.
The community thing is next week.
Huh?
The community thing is after the test next week.
Yeah. I'm still gonna ask her though, like, can we get some kind of info? Because that's a lot. You know, she might say no, but it's worth asking. Especially considering they gave us these crappy ass outlines. It's not like we have a lot of PowerPoints that we can review. Because I feel like my notes suck.
We'll tackle the non-malignant hematological disorders first.
Those are good, but
The
they're
headers
too
you see
detailed.
on your handout,
Exactly.
and it starts with the anemias. And the NCLEX questions I combined, so we'll do them at the very end of the class. I got them, the oncology and hematology ones together. Okay. These fall into the non-malignant hematology neoplasms. So these are not blood cancers. These are hematological conditions. Anemias, as you know, the definition is decreased red blood cells. As you can tell from your handout and your reading, there's lots and lots of different types of anemias. The theme is the same. The theme is the patient's going to have decreased red blood cells, and it doesn't really matter from a nursing standpoint whether it's an issue of not getting enough produced or the issue of them getting produced but getting destroyed. It makes no difference at all. So you don't have to differentiate between them because you're worried about caring for your patient, what caused the anemia, and management of that.
Question.
So the issue is the low red blood cells equates to low hemoglobin. That's the amount of oxygen your red blood cells can carry around with you, and that's going to be causing the problems for your patients. The issues that go with you having low hemoglobin, there's lots of symptoms that go with that. They're pretty straightforward. This group, you don't have to differentiate that, but the problem with this next group of anemias coming up is that there's not enough red blood cells that get produced as a fact. One type is related to low iron levels for your patient. That's going to cause her anemia. In the United States, the most common cause of iron deficiency anemia is blood loss. Because our diets are pretty good with having enough iron in them. So your patient presents with a low hemoglobin level, a low red blood cell count level. You're going to try to pinpoint what's caused her to have this anemia. Of course, do lab work and evaluate what her iron level is. Because most often you're going to start to try to pinpoint where the blood loss might have come from. Lots of things, as you can tell, a lot of them are GI related, things that cause you to have low iron levels. Again, low hemoglobin and hematocrit. Decreased size of the red blood cells is what that MCV means. Only way we can really diagnose it is to aspirate the bone marrow. On your notes, an unusual finding with iron deficiency anemia is these weird cravings that they may have. So as you go through, I would differentiate, maybe is there something unusual about this one that maybe is different than the next one. On your cover sheet are the symptoms we just went over. For all the anemias, your cover sheet will be all those symptoms that go with anemia, no matter what the cause is or what is going on. But iron deficiency's got these weird cravings. Also with this one is some of the neurological things that you can see. Restless leg syndrome, the smooth and red tongue. I would star those on your notes. That's a little bit unusual for this type. Different a little bit from some of the others. And of course, the treatment's going to be to try to replace her iron. Promoting iron-rich foods, which some of them are on here. Next, anemia is due to renal disease. As you know, the kidneys produce what hormone? Erythropoietin. We already talked about that last week. Because of your kidney disease, you don't have enough erythropoietin get produced, and therefore you have not enough red blood cells that get produced, therefore low hemoglobin. We covered all that last week. You could be anemic because you have an inflammation. You could be anemic because you have damage to the bone marrow itself. Which is responsible for producing all those red blood cells.
Would this be due to radiation?
It could absolutely be. That's a great question. So therefore, all the cells that your bone marrow produce are going to be depleted. That just makes sense. You just told me they have anemia because their bone marrow isn't working right. All the cells the bone marrow is responsible for are going to be depleted. Oftentimes this one is sometimes we find damage to the bone marrow due to an ingestion of a high amount of benzene products. So I would make that little star in your note. This is what is a little bit unusual about that. Benzene products are an airplane glue, paint removers. So your patient, find out where your patient works, what his hobbies are. Is there some connect there? So that is a risk factor. Because the whole bone marrow is messed up, it can't produce the cells correctly, we may have conversation about stem cell transplantation, which we already went over when we went over rheumatic diseases. Maybe it's due to too little folate. And all these deficiencies, as you can see, I tried to put a little one-liner in there. What does that have to do with red blood cells? Anyways, you don't have to know that that's what folate does, but sometimes I'm looking like, I don't know what that has to do with low red blood cells, just because I have low folate levels. God bless you. sizes of red blood cells go with this one. This one I would probably differentiate, kind of mark your symptoms with this one. As you can tell, they're more neurovascular symptoms as the patient experiences with this one, because that's what caused it, promoting increased folic acid in your diet. As far as hematology goes, I probably won't really ask you foods specific, like grapefruit, some of those. The foods will come into play, yes, definitely from last week's content. The potassium foods, caffeine, all those things. No, it's high in folic acid. I know, you all do. I know. As soon as I see grapefruit on there, I'm picking it. Don't let that get you, because that may not be bad in that case. Anemia due to low B12 levels. All these vitamins, all these things play an important role in keeping your red blood cells where they need to be. Little did we know. But B12 especially, when you have a low B12 level, it's usually related to something GI, as you can see. Because your B12 gets absorbed in your GI tract. Normally, unless you've had one of these conditions, you don't have trouble with low B12, just by the way things are designed. But following any of those kinds of surgeries, you may experience low B12. Absence of intrinsic factor is you were never born with a factor that absorbs your B12. The other causes, you had something that occurred as a patient that caused you to have low absorption. The bottom bullet is you never had the factor to begin with to absorb your B12. When that is the case, that's called pernicious anemia. Pernicious anemia is you were not born with a factor, intrinsic factor, that allows you to absorb B12. That's called pernicious anemia. You will be on a lifetime of B12 vitamins, so you can't absorb it because you don't have the factor that's needed. And we'll put you on lifetime B12 so we don't have you develop anemia over your lifetime. Low B12 levels, your body compensates for a long time. Again, the smooth red tongue, the neuro issues, oral supplements of B12. Questions about that one?
What's the difference in between the pernicious and regular anemia?
A regular deficiency was caused by some acute event.
Okay.
You had GI surgery, you got Crohn's, some reason that you have the intrinsic factor, you've been absorbing it, but you've had some condition or event that has caused you to not absorb it the way you need to.
Okay.
Pernicious anemia is you never absorbed it to begin with.
Okay. Okay.
Because you weren't born with that factor.
Okay, thank you.
So, a couple slides back, you had said, Hallmark lab vitamins decrease MCV.
Yes, and you don't have to know the sizes of, MCV is the sizes of the red blood cells.
So,
Sometimes they're big, sometimes they're little, you don't have to know that as a student. Is that what I was supposed to say?
yeah.
Because it doesn't matter. I mean, it matters, but it doesn't really, right? You're still treating anemia, you still gotta figure out what caused it. And I don't really care if you know whether they're big or little.
It's bigger small. Okay.
I'll tell you if I need to know that. Because you need to know that. There's so many other things in your brain you gotta keep track of beside that. Okay, so all of those anemias I just went over, there was not enough red blood cells that got produced for whatever reason, for all those reasons. Now we're talking about anemias that fall into a different category, is the red blood cells get produced, they get destroyed too early until they can do their job. Sickle cell disease, we'll talk about sickle cell crisis, which is important. Sickle cell disease is that those cells are formed shaped like sickles. Like sickles that they used to use on the farms, like the hack at the, whatever they're doing. Instead of round marbles, like yours are shaped, theirs are shaped like sickles, and they get stuck. They don't flow through really nicely. It's an inherited disease. Again, pick different parents if you don't want sickle cell disease.
Let's put them up for adoption.
At risk are persons of African descent is a risk factor for sickle cell disease. You didn't cause sickle cell disease as a patient. It's inherited. Your cells are supposed to be round and marble and flow through nicely, but your cells with sickle cell disease are shaped like sickles. They get stuck in the bloodstream, just by the way they're shaped. Oftentimes we can diagnose it in childhood. They start to have issues early on. Life expectancy is not sometimes great. We've come a long ways with that, but because they're just inherently shaped that way, we can't really fix that as far as fixing the way they're shaped. That's what causes you to have anemia, because the way they're shaped. Diagnosing is looking at your red blood cells and noting that. You start to evidence symptoms of hypoxia. Your blood's not flowing through real nicely like it would be if they were marble and round. Lots of things that go with hypoxia. Crisis is when they get stuck and they block traffic and they impede blood flow. Causing you to have intense pain, the same pain you have when you have chest pain with a heart attack, or same pain when you have pain when you've got occluded blood flow anywhere else. Same thing. Because they got bunched up and they've gotten stuck and they've impeded your blood flow. This is important to know. These are some things that will trigger you, could trigger you. You being the patient that has sickle cell disease, for you to go into a crisis. These are researched and found triggers for that. Important for you as a nurse to know. So you can identify by their history maybe what brought this crisis on, and for you to educate your patient about these things. You have sickle cell disease. That was diagnosed quite a long time ago when you were a child. Let's try to learn about, monitor, prevent things that are going to trigger you to go into crisis mode. Crisis meaning that your cells get bunched up and they impede your blood flow. Your big jets, they're pressurized, but your little small airplanes are not. So small aircraft that aren't pressurized can cause a sickle cell crisis. High altitudes can cause sickle cell crisis. So you go hiking in Denver, you go places, climb mountains, that can cause that. Infections, dehydration, changes, big swings in climate. So we tell these patients, you know what, we want you to keep your room at the same temperature all the time. Because we don't want the big fluctuation in your temperature, or we don't want you going out when it's 20 below, or going to the beach when it's 100 degrees out. Because that may trigger you to go into crisis mode. Emotions, procedures, surgeries, babies. Vaso-occlusive, as it says, it's included the vessel completely. The cells have gotten bunched up, causing hypoxia. Normal, typical symptoms that you would picture, imagine, anytime we block your circulation. Treatment is to manage the symptoms. Your priority is keep them breathing, circulating. Aplastic is another type of crisis. This one is what we call the crisis that occurs when they bunch up within the spleen. We have lots of treatments that we can do. There's some great things that are happening to prevent the cells from getting bunched up. This is key for you as a nurse. Key for you as a nurse is either A, to prioritize that patient, keep him breathing and circulating when he hits your door. B, to prevent him from having triggers, or to identify triggers. I'm going to give you some patient education about things that you can do to prevent yourself from going into crisis mode. No high altitudes, no severe swings in temperature. Try to manage your flu. Get a shot, because the flu may set off you to have a crisis. High altitudes, non-pressurized flights. Those are things like helicopters, small airplanes, not the big jets. They're pressurized. Pardon me? I don't know. Probably coin toss on that or see what the other labs are doing. The question is about should they avoid live vaccines? Because it's not really infection, I don't know. It might be. Don't go there next week, but it's a good thought. But you flying on your airplane will be pressurized when you go to Africa for your mission trip to do a live vaccine. Yep, so. Questions about triggers. It'll be definitely most likely be a patient education piece of it. It's important to educate our patients how to keep them out of crisis mode. Or given a patient chart, when you come to a sickle cell crisis, could you figure out maybe what triggered it? Lots of body system involvement, as you know, with impeded circulation. We can do stem cell transplantation. We can give meds that are hopefully improve the circulation. We got multi-organ failure. We can also talk about transfusing. Some of these I'm going to buzz through pretty quickly because we could be here all day talking about all these different anemias. The theme, the cover sheet will be the symptoms that we started off with when we talked about those. Again, decrease in hemoglobins. Lots of diagnostics to figure that out. This deficiency makes the membrane unstable. There's different causes of anemia that are related to X-linked defects. Some of those are always interesting to kind of track back. This one maybe. Triggers, this could be for any of anemia. Triggers for red blood cell breakdown. NSAIDs is a culprit, and the copper street drugs are found to have been a cause for you to have red blood cell deficiencies. This is when the antibodies destroy themselves. As the word says, immune hemolytic anemia. Hemolytic means breaking down because of a self-attack. And sometimes those bunched up cells like to sit themselves into your spleen. So we'll find that when we get to some of the chronic leukemias also in a bit. This is probably the biggest, most important part of this type of anemia. Because the system self-attacks and they're anemic, and you're going to give him some red blood cells, what could happen with those red blood cells that you're going to give to him? The body can also self-attack. So we have a situation where the body self-attacks their own red blood cells. You're going to try to promote red blood cells by giving him red blood cells. And the body is at high risk for also attacking the ones that you're going to give to him through his IV bag. So your job as the nurse, knowing that could be the potential risk, is to start it very slowly and keep a really, really close eye on your patient. Knowing that he's at risk for breaking down those cells that you're giving him in his IV bag, because that's what his anemia is. So this is the biggest caution that you as a nurse need to be really promoting safety and monitoring that. Yes, actually.
And how do you know while you're transfusing that they're attacking?
What could be going on with that? They could be developing your typical symptoms of a blood reaction. Low blood pressure.
Will it be within like the first 15 minutes or?
Yes, it could be, but it also knowing that that's the state he's in, it could be high, for him, it could be high risk throughout his transfusion. Typical patients that don't have this, you're exactly right. The hemolytic reaction typically occurs in the first 15 minutes. But for him, in theory, we could have it occur anytime.
But it's going to present as like a reaction to the blood products.
Yes.
Okay, and you would just stop the transfusion?
Yes. And we have to come up with plan B for increasing his red blood cells.
And would that be food?
I don't know, probably one of those medications that we just went less fast. Yeah, hard line to follow, but good questions. Again, what caused it is the question, and if it's a bunch up in the spleen, of course, we may have remove the spleen, promote pneumonia vaccine, influenza vaccines, those that are not live virus vaccines. And immunosuppressives, as we talked about already, because if it's a self-attack, it's an overdrive of the autoimmune system, so that's the issue. Here's where there's too much iron that gets absorbed from the GI tract and it goes parks itself other places. Iron builds up in the organs, causes all kind of organ issues. In this case, because there's too much iron built up, we may have to have a patient come in with for therapeutic phlebotomies, where we remove iron from your bloodstream because you have this hereditary condition. 1 unit of blood removed decreases your iron by 200 to 250 milligrams. So it's effective if we just got to keep managing your overload of iron. Some of the students have seen them do that with patients in the cancer care center. Oh, really? Well, timely. How often was that patient getting them done?
I think he was coming back like every 6 weeks or so. But he's been doing it for 15 years.
And he comes back how often? Every 6 weeks?
Every 6 weeks. But I think he's starting to get to a point where they're like, okay, we can start spacing it out. And I think they said he was going to maybe every couple months now. But she said usually they drain out about 500 milliliters every time. Because he's just constantly.
So Jordan said they had a patient yesterday. He comes in for these every 6 weeks for the last 15 years.
So is it like, kind of like how like dialysis is, where they're like cleaning the blood, or are they taking it out?
Taking it out.
Taking it out.
Yep.
They don't replenish the blood. But do you get
The blood's too thick.
time, or you just
What?
lose what you got taken out? Like, do they replenish it, or they just leave it?
They don't replenish it, but you
So
replenish
you
it
just get
yourself
it
and then you
taken out.
overload it. And you're back again 6 weeks later.
So can they like donate blood?
I would say probably not, but
Yeah.
because it's all autoimmune stuff going on. And then as you know, if we're checking the hematocrit and trying to figure out how often we have to do them to keep the patient well. But every 6 weeks for 15 years, that'd be a long time. I mean, it's like, oh geez. I'm glad I picked a different set of parents, so I don't have that. We don't want to do anything that's going to increase your iron absorption. Okay, polycythemia. Poly means many. In this case, there's too many cells of all types. Which way will your hematocrit go? Up. Which way will your red blood cells go? Platelets, white cells, all of those. So the problem with this condition is there's too much going on. This little first tube shows your proportion and ratios that you're supposed to have normally. The third tube is what's going on with this patient, evidencing increased hematocrit. So there's an imbalance of red blood cells. In this condition, this patient has too many red blood cells, as the word says, and this is what he's experiencing. Instead of that first nice ratio, he's having too many red blood cells. The bone marrow overproduces. So primary means that your bone marrow is just not functioning correctly, nothing that the patient did, but that's just how it was created. Secondary polycythemia is there's some kind of activity, disease, condition that caused him to have an overproduction of red blood cells. So anemias were not enough red blood cells. The condition we talked about before was there's too much iron. This condition is too many red blood cells. That's the problem. Making for thick, viscous blood, poor blood flow because it's too thick. It's like ketchup thick because there's many cells floating around in that bloodstream. Red, congested, thick, not flowing nicely because it's too thick. Again, we may have to pull off some blood till we get your hematocrit where we want it. We want your hematocrit to be like that first test tube or that first tube on that first slide. Questions about polycythemia? Too thick, too many cells of all kinds. Neutropenia, different condition, different day. Leukemia is decreased number of white blood cells, as the word says. Lots of things could cause you to have a low white count. A and C, we talked about that earlier. That's the phagocytosis. That's the neutrophils that can do a good job of phagocytosis, chewing up the debris, getting rid of it. Lower the number, worse things are. Does that feel like it's been an eternity ago? It feels like yeah. Just it's like, oh my gosh, we've been talking a long time ago. One consideration is if you've got a patient's got neutropenia and you're trying to rule out what it might or might not be, if he's taking corticosteroids, he may not present with an infection. If he's an older adult, he also may not present with a fever. So just because mom doesn't have a fever doesn't mean that she may not have an infection. Okay, this one is a low platelet count, as the word says. So polycythemia was too much of everything. All the counts were up. Break the word down, you'll figure out what's too much or too little. In this case, low platelet counts, therefore causing low hemoglobin, low hematocrit. Symptoms that go with low platelets. Bleeding, bleeding, bleeding. Other indications of bleeding. To treat or not to treat depends on what the number is, how it's affecting the patients, so forth. You may have to give in platelets if the number gets too low. Okay, this case is too little platelets, but it's some kind of stimulus that caused platelets to get destroyed. And sometimes we don't know. Because you have too little platelets, you're going to have the same symptoms that go along with bleeding. Not that unusual or unexpected. Try to get you to a safe platelet count so you're not going to bleed to death. Maybe we need to boost your immune system, because the problem here is with an immune deficient response. So IVIGs, we could use them. We need immune boost. Stay away from the herbs, the meds, the things that cause you to have decreased platelet function, which some of you all missed that on the last question. I think the most missed was probably the ibuprofen, right? That's an NSAID, that increases your risk of bleeding. That question, that was probably the one that was most missed, as far as people not picking up on that. The G herbs. Sometimes the problem is just a defect with the platelets. The platelet count might be normal, but the function is not. Things that could cause you to have increased bleeding, as we just talked about 10 seconds ago. Stay away from that which caused it. I love that. Commercials like, do not take this med if you're allergic to this med. Yeah, duh. I got it. Okay, hemophilia. There are two types. A is a lack of factor H. That kind of rhymes. That's why I know that goes with that one. A is 8 and B is 9. Both of those factors are needed to stop bleeding. Both are X-linked traits. Most of the time, the affected people are males. Females can carry it, but they aren't usually symptomatic. The problem is, it's usually a bleeding in the joint. They don't have a needed factor, whether it's 8 or 9, that causes you to clot when your knee gets injured. It does not allow them to clot when their knee gets injured or their joint gets injured, and that's where the problem is. Can occur in all body parts, typically in the joints. They bump their knee when they're outside. They come in and their knee's this big around, and they've got bleeding. They can see a hematoma develop immediately, unlike if you just mildly bumped your knee. In the caution, of course, the most concerning area of bleeding would be in the head. So you walked out of here, you bumped your head on the doorway. That's their biggest concern for them, because they may have bleeding that goes on immediately, unlike you who have normal platelet counts. Yes?
So can it be A and B, or is it always A or B?
There's not always the case, it's usually A or B.
You're right.
But we're human beings, so they may have A and B combo, but usually it's A or B.
Okay, thank you.
Good question. So indications of bleeding, as we've discovered. Factor replacement therapy, especially if they know they're going to undergo something traumatic. I'm scheduled for a tooth surgery coming up. I'm scheduled for some other kind of surgery that I'm aware of is coming up, some other surgery. So they can load them up with a factor that they're missing before they even head into surgery. Maybe we get you loaded up with that factor so you don't have bleeding concerns while you're in surgery or post-operatively. There's medications that can increase your factor that you're missing. Patient teaching, be proactive, load up with your factor before you're going to go into something invasive that you know is going to be potentially a risk for bleeding. Stay away from the herbs, meds, things that are going to cause you to have increased bleeding. You can avoid injections, make people aware that you have hemophilia, and sometimes then they just keep factor at home, the missing factor at home. They wake up tomorrow morning and they've got bleeding in their knee because they were out last night and they did something that maybe traumatized that. We had somebody in our wedding party that has hemophilia, and he danced at our wedding, sent a picture the next day of his knee, and it was like, he goes, worth it. I'm loading up with factor 8 today. I'm like, okay. Questions about that one? This one is deficient protein. Like you can see, there's a bazillion things that cause you to have bleeding issues or platelet issues. Same thing, increased bleeding. We replace the factor that's missing. Maybe due to your liver dysfunction, almost all your clotting factors are made in your liver. Liver problems equates to sometimes clotting problems. Maybe the coagulation disorder is related to you having a lack of vitamin K. Sometimes long-term use of antibiotics causes a low potassium level. The potassium teaching now with vitamin K deficiencies or vitamin K concerns is try to keep your vitamin K intake of green beans and that leafy greens at a constant level. Don't do this up and down thing with your foods that change your vitamin K levels. DIC, we just talked about that. Clotting, bleeding, all at the same time. We talked about the labs just a bit ago. Indications of bleeding. Again, the treatment, we just discussed that. Trying to stay ahead of that game. Okay, maybe the coagulation is related to too much homocysteine. Increased risk of clots, so that just makes sense of increased coagulation. Maybe there's a decrease of antithrombin levels. Anytime you have too much clotting going on, you're at risk, obviously, for PEs, DVTs, strokes, all those kinds of things. So I would say for these disorders, when you're trying to sort them out, which way is it going? Is it too much bleeding, concerns that go with that. Is it too much clotting? What complications or symptoms or issues go with that? Kind of in your head, keep that clear as to, well, what's going on with this one, what's going on with that one, without worrying necessarily about some of these, because we could be here all day talking about what could cause you to have all of those. Okay, so for anticoagulation therapy, that may be a prescription for that patient for whatever reason. When you're on warfarin, you do have to go in for regular lab work testing. If you get sent home on warfarin, if you get sent home on one of these other ones that are listed here, they are anticoagulants. You don't have to have blood work done to monitor your INR, your PTT levels, stuff like that. So sometimes I'll get like, how do they pick who gets what? Well, if the patient has a broken leg, they've been immobile for 3 months, I'll probably send you home on something other than warfarin. One of these other ones just keep you from getting a blood clot while you're laying there in bed. My sister that had the PE, she had a major event. She will be on warfarin the rest of her whole entire life. Little event, maybe we'll put you on anticoagulant for a period of time. Big event, we may have you on that forever. So you're educating your patient, and he says, well, I got a prescription for Eliquis. Do I have to come in for any kind of lab work? No, probably actually once a year, like your routine lab work. Or he says differently, I got sent home on Coumadin. Well, yes, you're gonna have your lab work checked. So advantages are, if we keep an eye on your lab work, we can easily dial in your right dose for Coumadin, right? Otherwise, we send you home on other ones, and we're like, well, we're hoping that your clotting and your coagulation and all that stuff's exactly where we want it. Teaching your patients about anticoagulant foods. Again, these will make your blood thinner. Be consistent on your intake. These are also vitamin K rich foods. All your leafy greens are there. This coagulation disorder is related to protein C. I just want to know who sat and figured all these proteins out. Who does what? How they know
I
all
don't
that
have enough attention span for that.
What did you say?
I don't have a good enough attention span for that.
I know. I don't either. Protein S levels. Again, too much clotting, too many platelets are going to cause all these same problems with too thick of blood, an increased risk of stroke, blood clots, embolus, thrombosis, all that stuff. Anticoagulant therapy, we already talked about that. Complications, of course. You take your Coumadin, you send your blood too thin, and you've got issues of bleeding. Again, protein resistance. A constant state of thromboses, clotting, blood clots, especially in critical veins, vessels. Anticoagulant therapy again. Heparin. You guys already studied heparin on the talked about strokes, right? I'm not going to go over that again. Too little platelets because of too much heparin. Monitor your patient for signs of bleeding, signs of clotting, clogging up. Aspirin sometimes, the thought used to be, let's just put everybody on daily baby aspirin if we think you're at any kind of cardiac risk, if you're a certain age. And not very long ago, I went into the cardiologist with my father, and the cardiologist goes, we're kind of like not doing that anymore. And so what medications do you take? And my dad said, well, baby aspirin every day. And he goes, we just aren't really doing that. Unless we have a perceived need, we just sort of think that's not necessary anymore. So stay tuned. Okay, questions about those? Yes. So really, what is the only one that we actually have to check your lab work? Tune it in. And that would be prescribed if we need to keep you closer eye on your anticoagulant levels, you know, your INRs and stuff, especially if you had a big event. Unlike if we put you on that for a kidney condition, we put you on something else, or actually one of those guys. Yeah, that's good patient teaching. Sickle cell crisis absolutely will be on there. That's a crisis, that's an emergency. And then just go through your notes and kind of what are some hallmark symptoms that go with some of the big ones we talked about. This is something unusual. Your patient comes in with this. What symptom do you expect to find? Your cover sheet for the ones that are too much clotting, your cover sheet for the ones that are anemia should be the same for all of them, right? Let me think. Low red blood cells equates to low hemoglobin. How does the person feel, act, how will they present if they don't have enough hemoglobin on board? Much different than a patient that's got too many platelets. What kind of things go with people that have too much clotting and too thick of blood? That's how your brain needs to separate those out. Break the word down. Polycythemia, too many cells. Penia, neutropenia, thrombocytopenia. Too little of those things. So it should be easy to figure out. Just break the word down and say, okay, is it too much, too little? Knowing that, what issues will they have? It's probably my best advice on how to tackle all of these. Questions about that? We're doing half-hour lunch today, right? It's 11:20. So,